Good morning, all. Thank you for the introduction, and thank you once again for the invitation to come and present a plenary on the long-tail impacts of COVID on the mental wealth of nations at this 30th anniversary of the Swiss School of Public Health Summer School. I consider it a real honour to be invited, and I very much wish I was in Lugano right now, but unfortunately I'm locked down in Sydney, Australia. Before I launch into the presentation, I thought it may be best to provide some context for the work we've been doing over the last 6 years or so, which has primarily been applied research aiming to help address some of the significant challenges policymakers face in trying to address complex health and social problems. And those of you working in the health policy planning and system strengthening space will know that these challenges include the complexity of many population health and service delivery problems that offer up many potential points of intervention. There are often a broad range of options for intervening, supported variably by evidence. And there's uncertainty about the likely effects of different combinations of programs and initiatives and the interdependencies between them. And there's uncertainty about how they will perform in different contexts. Also, service needs change over time, and there are often many perspectives on a problem and competing views on what should be done, which can prevent consensus on the best course of action. So systems modelling provides us with a way of mapping and quantifying a complex problem, bringing together best available evidence, data, and expert and local knowledge to produce an interactive decision support tool that creates a safe virtual environment for forecasting the likely impacts of policy changes and major investment decisions before they're implemented in the real world. CSAID and its partner institutions have been committed to taking systems modelling out of back rooms and into meeting rooms, exposing the work to open, transparent, participatory processes. Having a broad range of stakeholders from across the system get under the hood to critique the structure, the parameters, and the assumptions that underpin these models helps ensure that the final tool is credible, it's valid, it's robust, and importantly, it's grounded in the local context. It also generates greater confidence among stakeholders in model outputs and insights and facilitates a consensus building for collaborative and coordinated actions. Once the model is built, we then overlay an interactive interface that allows end users to ask what-if questions. It allows them to turn interventions on and off, scale them up and down, stagger their implementation, and test the impacts of different combinations of interventions against a baseline of business as usual. The model can then be used to help weigh up the quantitative trade-offs of selecting one suite of interventions over another and help decision makers determine the best targeting, timing, scale, frequency, and intensity of interventions needed to deliver real impacts. It allows end users to see the impacts of intervention scenarios on a range of outcomes by scrolling through the different graphs. And the results can also be viewed numerically or in any way that's meaningful to stakeholders to facilitate policy dialogues and build consensus for collaborative action. The costs associated with outcomes, with service utilisation and interventions can be integrated into these models and be assigned to different payers such as federal government, state government, or consumer out-of-pocket costs. And when interventions are switched on, the annual and cumulative costs incurred in health systems and more broadly are dynamically calculated. The flexibility of these models and the different interfaces facilitates a highly flexible and pragmatic approach to economic analysis that might be of interest to different types of funders, such as a public finance perspective showing return on investment, a health sector perspective, reporting on cost effectiveness or cost utility of alternative strategies, and a societal perspective allowing cost benefit analysis. And importantly, this allows end users to more easily explore the implications of considering alternative time horizons on the outcomes of economic analyses. So in the interest of transparency, we put as much information as possible in the interface. So for each of the interventions, we have a control panel that looks like this, that it makes explicit the assumptions, the default parameters, and allows end users to change those assumptions and explore what the implications might be. There's also an information button that provides more detail about how the intervention was defined, how it acts in the model, and the evidence and data sources used to derive the parameter estimates, which is just up here. For those unfamiliar with systems modelling, it's an umbrella term for the modelling methods of complex system science and includes system dynamics modelling, agent-based modelling, and discrete event simulation. It's the type of modelling used in the pandemic response. For those governments that engaged with it, systems modelling helped inform timely and effective investments and actions to control virus transmission, manage demand for critical care services, and inform vaccine prioritisation and scale-up strategies. While systems modelling has long been used in infectious disease control, it's underutilised in other areas of public health policy and health system strengthening. And one of those areas that systems modelling will be urgently needed in the wake of this pandemic is mental health. Many countries and international agencies now recognise the serious, widespread impacts that COVID-19 and recession are likely to have on population mental health outcomes, mental health services, and suicide risk, particularly for young people. To understand how best to respond, decision makers require credible projections of population mental health trajectories, as well as the ability to simulate mitigation strategies to guide strategic actions and forward planning. Without systems modelling, the complex interplay of social determinants, service system factors, population demographics, and behavioural dynamics makes it extraordinarily difficult for decision makers to determine the nature and balance of investments required to have the greatest impacts on population mental health outcomes and suicidal behaviours. Real-world experimentation to establish the optimal combination of programs and initiatives across the social determinants of mental health outcomes, or the allocation of resources for optimal system performance, is really unfeasible within the timeframe needed to inform effective action. And so over the past 18 months, the Brain and Mind Centre at the University of Sydney, which is a key institutional partner of CSAT, has been undertaking systems modelling to inform national, state, and regional mental health responses. And this is a high-level view of the system dynamics model of the social and economic impacts of COVID-19 on mental health, developed by Dr. Adam Skinner and Dr. Nicholas Ho of the Brain and Mind Centre. So there's no time today to describe it in detail, except to say that it captures population dynamics. So it captures changes over time in the size and composition of the Australian population, resulting from births, migration, ageing, and mortality. It captures changes in psychological distress. It models a range of social determinants of mental health and suicide. It captures mental health service dynamics, which I'll show you on the next slide. And it has a suicidal behaviour component. And so just to show you how the model operates, if we zoom into the mental health services component, and I'll just play the video. So this component captures the movement of psychologically distressed people through one of several possible service pathways, involving potentially general practitioners, psychiatrists, and allied mental health professionals, emergency department presentations, psychiatric inpatient care, community and hospital-based outpatient care, and online services. And when we run the model, the proportion of the population waiting for services or receiving services changes over time based on different rates of flow into, within, and out of the service system. A broad range of health, education, and economic data sources have contributed to informing the structure and parameterization of this model, which importantly also includes the knowledge of people with lived experience of mental health issues and suicidal behaviour. The model was validated by making sure it could replicate historic time series data across a range of mental health indicators, giving us greater confidence in the model's forward projections. So on to some key findings. So even prior to the pandemic, the rate of suicidal behaviour was increasing in Australia. And given the majority of suicide deaths occur in men, and given that the temporary economic protections put in place benefited men to a greater extent, Australia was successful in preventing an overall increase in suicides in 2020. But our projections estimate that over the next 4 to 5 years, Australia is still likely to see a 6.5% increase in suicide deaths. And this is in a country that was able to keep coronavirus transmission at relatively low levels, allowing a rapid bounce back in economic conditions. So while men make up the majority of suicide deaths, women are more likely than men to be hospitalised for intentional self-harm, which is a proxy for suicide attempts. Of the projected increase in self-harm hospitalisations, a greater proportion of that increase is among women, widening the gender gap. While simulating baseline trajectories of population mental health outcomes can help us understand the scale of the challenge ahead, the real value in systems models is their ability to simulate a range of possible mitigation strategies. And doing so revealed a number of important insights. The first is that some seemingly worthwhile national investments that were made were unlikely to deliver the anticipated impact. So one example is the expansion of helpline services. So the blue line is the baseline COVID mental health trajectory, and the red line, which is run 2, is the impact of helpline services. The limited impact is explained by the fact that when service capacity is limited and already stretched, as is currently the case, it's difficult for helplines to link to specialist community-based services that are needed to deliver more substantial care. So investments in helplines on their own are relatively ineffective as a public health response to the mental health challenge. Some programs are projected to make things worse. Again, the blue line is the baseline, and the red line is the projected impact of mental health awareness campaigns. And while research evidence suggests that population-wide community awareness campaigns are effective in reducing stigma and increasing the recognition of symptoms of mental ill health and improving treatment seeking, they act to drive more people into a service system. So when that service system is already stretched, wait times increase, which drives up emergency department presentations because people in crisis can't wait 4 to 6 weeks for care. Another key insight of the modelling was that some of the most effective programs to reduce adverse population mental health outcomes lie outside of the health sector. Job creation programs, particularly those targeted at women, are the single most effective strategy for reducing the adverse mental health impacts of the pandemic. Increasing the rate of female employment initiation, coupled with the provision of affordable and accessible childcare, is projected to reduce the duration of psychological distress and start to reduce the gap in self-harm hospitalisations. Despite the good impacts of employment support programs, though, large additional investments in community-based specialist mental health service capacity are required to address the COVID mental health challenge in Australia. While the impacts of increases in health system capacity introduced in 2021 are unlikely to be seen until 2023 and don't actually act to reduce the peak of the adverse effects, they do have an amplifying effect over time and significantly reduce the duration of the long tail effect of COVID on mental health. The best mitigation strategy actually comes from coordinated and gender-informed economic, social, and mental health programs and initiatives. So systems modelling in the Australian context recommends that the most effective combination is going to be employment programs, economic incentives to achieve an increase in the rate of female employment initiation, supported by affordable and accessible childcare, education programs aimed at increasing post-secondary enrolments by 20%, and significant investments in community-based mental health service capacity, technology-enabled coordination of care, and post-suicide attempt assertive aftercare. And this strategic combination of programs and initiatives are projected to prevent 63,000 or 4.1% of mental health related emergency department presentations, over 10,000 or 5.9% self-harm hospitalizations, and save almost 850 lives from suicide by July 2025. So as you can see on the bottom left graph, service capacity improvements do little to reduce the gender gap in self-harm hospitalizations, whereas the recommended suite of broader gender-informed policies have a more substantial impact on reducing the gender gap. So why is it important to capture in our systems modelling the broader social and economic drivers of psychological distress and mental health outcomes? If we consider the prevalence of psychological distress in a population as water in a bath, even when mental health services are scaled up and working to reduce psychological distress, distress can keep rising in a population unless we address the drivers of distress and mental disorder, so the inflows from the taps. We need to understand in different contexts which of the taps or the drivers are contributing the most to driving up levels of psychological distress and mental disorder in the population, and by how much and over what time frame. And therefore, we can use the modelling to understand what the most timely, effective strategies for turning the taps down are so that services don't become overwhelmed. And mental health systems around the world are already overwhelmed, even in high-income countries. For example, using systems modelling to estimate the scale of underinvestment in mental health, Dr. Adam Skinner of the Brain and Mind Centre found that the investment required to ensure that all Australians with a mental disorder seeking care receive immediate and effective treatment is 2.74 times current expenditure, or approximately $22.7 billion per year. So Australia needs to spend $14.4 billion more each year than it currently spends just to meet existing demand for treatment. And that doesn't include providing treatment to those in the community with mental health issues that are not currently seeking care. So underinvestment in mental health and well-being is nothing new. There has been there's long been an underappreciation of and underinvestment in mental health and well-being. In part, this is because we have traditionally taken a deficits-based approach, focusing on measuring and avoiding mental illness, offering up estimates of lost productivity associated with mental illness, including absenteeism, presenteeism, and premature mortality, and relying on the health sector to respond, and being too preoccupied with individual notions of well-being rather than collective well-being. This approach doesn't wholly conceptualize the human and societal potential that could be unlocked by investing in national mental assets. And so as nations shift focus to post-COVID recovery, it is our hope that reconceptualizing mental health as mental wealth will help secure the coherent economic, health, and social policy and investments needed, not only to improve population mental health outcomes, but also to foster more cohesive, well-functioning and productive societies. And to this end, CSAT and the World Economic Forum's Global Future Council for Mental Health have partnered with the University of Sydney's new Mental Wealth Initiative. So what is mental wealth? It's a concept outlined by John Beddington and colleagues in their 2008 paper in Nature and expanded over a number of years by the leadership team of the Mental Wealth Initiative at the University of Sydney. To briefly summarise, a nation's mental wealth is generated not only from economic productivity, but also from what is termed social productivity of its citizens. And social productivity includes the value created by activities such as volunteering, participation in community groups, the informal help to friends, the role the grandparents play in education and care, and any activity that is socially valued and contributes to strengthening the social fabric of communities and nations. So social productivity contributes to national wealth through the strong, trusting relationships it fosters between citizens, communities, business, and public institutions. And these relationships build resilience and mobilize community resources to meet both individual and collective challenges and needs. Analogous to the well-known phrase in systems science that the whole is greater than the sum of its parts, the value created from social productivity is greater than the sum of the value of individual contributions. So next, we recognize that economic and social productivity are determined by the collective cognitive and emotional resources of citizens. And this includes people's mental capital, which is their cognitive ability and emotional intelligence, as well as their mental health and well-being. And these cognitive and emotional resources determine an individual's potential to work productively and creatively and to build and maintain positive relationships with others. There's a dynamic interaction between mental capital and mental health and well-being that determines the extent to which individuals across their life course can contribute to inclusive, cohesive, productive, and creative communities. So how a nation nurtures mental capital, mental health, and collective well-being through adequate education, employment and economic security, housing, healthcare, psychological and cultural safety, and through equal access to opportunity will have a profound impact on the well-being and resilience of communities, on economic competitiveness and on national prosperity. So this is all fairly intuitive conceptually. And we've been grappling with how to tell a more compelling story, how to make a more compelling case for governments to invest in the policies and programs that build mental capital and foster the mental health and well-being of the populations they serve. And we've been thinking about how to put all of the pieces of this complex puzzle together to quantify and better understand the dynamics that drive mental wealth. So factors that drive mental wealth are not independent. They are interrelated, and there are threshold effects and feedback loops that can drive nonlinear changes in mental wealth over time. And these characteristics challenge traditional analytic methods. For example, adverse economic conditions and industrial relations reforms aimed at enhancing business flexibility and creating private sector jobs can see labour markets increasingly characterised by insecure, fixed-term, temporary and casualised work. And these sorts of precarious employment arrangements can undermine the economic security of households. It can increase social dislocation and isolation. It can increase parental stress and marital tension. And it can increase rates of domestic violence and child abuse and neglect. And these adverse early life experiences can have effects on mental health and development. And in turn, this can lead to increasing rates of psychological distress, substance misuse, physical health issues, and behavioural challenges, and suicidal behaviour, all of which can result in significant functional impairment, further eroding mental capital, productive potential, and of course, then flows back to reduce labour market performance. So system science gives us the transdisciplinary framework and analytic methods to understand the dynamic interactions between health, economic and social systems. And by doing so, quantify and forecast the impact of policy and investment decisions on the mental wealth of nations. The UN Secretary General released a policy brief on COVID-19 in May last year for urgent action in putting mental health front and centre of every country's response to and recovery from the COVID-19 pandemic. The World Bank too has underscored the importance of governments investing in the human capital of their citizens by putting this agenda at the centre of a historic response to COVID-19. It's committed up to 160 billion US dollars as a primer to help countries rebuild with stronger, more equitable and more resilient economic and social systems. Individual governments around the world are committing trillions to social and economic aid packages. However, there remain two key challenges: understanding what impact those investments are likely to have, and determining how best to allocate funding and resources across the drivers of mental wealth to deliver the greatest national benefit. And the Mental Wealth Initiative hopes to help address these sorts of challenges. And the initiative aims to help policymakers understand the consequences of policy and investment decisions before implementing them in the real world, and help them choose the right policy levers to create the structures and environments where people can flourish. These policy levers extend beyond the health sector across the whole of government, the private sector and civil society. And so to achieve this, the University of Sydney's Brain and Mind Centre, along with national and international collaborators, are leveraging expertise in system science, systems modelling and simulation in mental health and economic analysis. The Mental Wealth Initiative is undertaking transdisciplinary research with researchers across the faculties of medicine and health, business, economics and law. The initiative is working with leaders across government, business, mental health and social policy and communities to measure, monitor and forecast mental wealth at national and regional levels. And by doing so, help identify policy opportunities to foster this broader measure of our national prosperity. We have on board former Prime Minister of Australia, Malcolm Turnbull, businesswoman and philanthropist Lucy Turnbull, economist and former Labor Party politician Craig Emerson, an economist, lawyer and former co-chair of the OECD Trade and Competition Committee, Professor Ellen Fells, all of whom are on our expert advisory panel. Discussions with potential international partners have begun in order to explore opportunities for coordination of international research efforts and contributions to the global mental health discourse. And the World Economic Forum Global Future Council for Mental Health and CSAT are on board as formal collaborators of the initiative. So building on the existing mental health related systems modelling work undertaken during this COVID period, the Mental Wealth Initiative has compiled some preliminary objectives, which are to identify, value and model the primary drivers of mental wealth in the first instance. Then to use the systems model to forecast and report regularly on the mental wealth of the nation. To use the model to simulate the impacts of a range of social and economic policies on national mental wealth, and to strengthen the data ecosystem to facilitate model refinement over time. The initiative will also work to facilitate development of new institutional capacity that nurtures positive factors shaping national mental wealth. So this initiative is working with a broad range of collaborators to refine and advance these research objectives and secure funding for a range of complementary research themes that will feed into the primary objectives. And we'd very much like to hear from those of you already undertaking research in these areas where we're keen not to reinvent the wheel, but to really bring the research community together to achieve something greater than what we could achieve individually. So I just wanted to finish by emphasizing that systems modeling and simulation is not a new analytic tool. It's actually the third pillar of science after theory and experimentation. Simulation allows researchers and decision makers to move beyond what we can manipulate within the scale, time, and ethical limits of the experimental approach. Systems modeling and simulation provides immediate outcome feedback for a range of decision options under different conditions. It allows testing of alternative assumptions and extremes and can elicit in a short period of time the learning of a lifetime of implementation, evaluation, experimentation, and experience. Such learning, when achieved collectively, has the potential to enhance community self-determination. It can help us move beyond incremental adjustments to the status quo and catalyze collaborative, cooperative, and effective transformational change. Thanks very much for your time.